Good morning, everyone. My name is Mehmet. Today, my team members, Javier and Chuan, and I would like to talk about intraoperative breast cancer margin determination technique by using quantum dots. First, I would like to give some medical information about breast cancer and its surgery. Breast cancer is an uncontrolled growth of breast cells. It is the most common cancer type in women. In the US, 1 in 8 women has breast cancer each year. And again in the US, each year, 1 in 5 patients dies from breast cancer. In breast conserving surgery, surgeon removes only the breast tumor along with the small normal surrounding tissue due to the cosmetic reasons. 75% of patients who need surgery chooses lumpectomy instead of mastectomy. The most important part of breast conserving surgery is determining the cancer margin. There are 3 types of margin for breast cancer: positive, close, and negative margin. After breast conserving surgery, the cases with positive or close margin requires another surgery. The rate of secondary surgery is 16% to 60%. Actually, it really depends on surgeon. Mortality risk is 20%. And local recurrence of the cancer is 15%. There is an unmet problem. The problem is there is no reliable and rapid intraoperative margin determination in practice currently. 80% of surgeons also agreed to have a better method than current ones. Our goal is to develop a molecular fluorescence imaging method for intraoperative breast conserving surgery, margin assessment that is rapid and reliable.
The idea of this project is to conjugate quantum dot with monoclonal antibody to form a molecule probe. The probe can specific binding to the biomarker to do the detection. The biomarker they use is T antigen, which is only appear on the cancer surface. The T antigen biomarker have been found to have 90% specificity for breast cancer in the lab, and it allows for localization any cancer cell on the margin by the method show. For imaging tissue, it only takes about half an hour. In this part, I will introduce quantum dot. Quantum dots are semiconducting nanoparticles with photoluminescent properties. Generally speaking, after absorb the light energy, the electron in quantum dot will jump from the valence band to the conduction band. Eventually, those electrons will jump back, and the absorbed energy will be released in form of photoemission. There are several advantages by using quantum dot to generate bioimaging. The first one is emission spectrum of quantum dots can be changed by changing the size and the composition of quantum dot core. Biological structure can emit the light automatically. This property is called autofluorescence. Autofluorescence has always been a challenge for fluorescent imaging, especially in tissue with high fat content, such as breast and liver. Normal tissue are known to emit autofluorescent signal at range from 380 nm to 550 nm under UV light excitation. We can use quantum dots which have near-infrared emission spectrum such as 700 nm to avoid this noise. That is why the quantum dots are very favorable for biological detection. Quantum dots are inorganic particles. Those particles have the resistance to bioblanching and metabolic degradation. That is second advantage. Finally, quantum dots also have a very high extinction coefficient. In Dr. Shi's lab, they use a novel method to synthesize the quantum dot. Instead of using organic precursor, they use the inorganic one. In a single step, they produce quantum dot with many carboxyl groups on its surface. It allows much easier bioconjugation and reduce antibody costs 120 times for proposed application. Furthermore, compared to the commercial quantum dots, which are made at 1 mil per dollar, the aqueous quantum dot is 3 mil per dollar, meaning further savings. In Dr. Shi's lab, they are already successful in imaging cancer cells, imaging the animal tumor in vitro, and imaging the tumor in whole mouse. They are testing this method in real human sample.
In this slide, I would like to talk about gains and losses to patients, physicians, hospitals, and insurers. For patients, this technology initially reduces the surgery cost. In addition to reducing the cost, it reduces also the rate of secondary surgery, mortality, and local recurrence. So it is totally good for patients. For physicians, the technology causes fewer operations, meaning a more desirable rate of successful patient outcomes. It is also time saving. As you know, physicians want to make money. However, they make less money because of fewer secondary surgeries. For hospitals, the technology provides economic benefits of reduced operating room procedure time translating into measurable cost benefits. But it also reduces the money that hospitals earn due to the fewer secondary surgery. For insurers, it is good as well. It lowers expenses of treatment. In this slide, I would like to give some important information related to the market that we want to get in. In 2010, 1.5 million people were diagnosed with breast cancer all over the world. 75% of patients who need surgery chooses breast-conserving surgery. As we mentioned before, for breast-conserving surgery, we need a reliable, rapid intraoperative margin determination technique. Our technology is able to cover the unmet problem of potential big market for less money. If you look at the graph on the right-hand side, you will see that in low-income countries, rates of mortality to incidence are higher than high-income countries due to the higher expenses of primary and secondary surgery. By reducing expenses, we can also cover low-income countries. This increases the market. By using our technology in other cancer surgeries or other fields, such as brain cancer, prostate cancer, and liver cancer surgery, and tissue biopsy, we would also be able to have large market.
We will now consider the competitive landscape. The current standard of care for margin determination is palpation by the surgeon combined with wire or ultrasound guidance. While these techniques guide the surgeon as he is excising tissue and not after the fact, they fail in guaranteeing clear margins more than 20% of the time. Touch preparation cytology, where slides are pressed to the surface of the excised tissue and studied for the presence of cancerous cells, is relatively simple but requires a trained eye, time to scan slides under a microscope, and has a relatively low accuracy compared to a full path report. Frozen section analysis attempts to simulate full lab workup quickly by freezing the tissue to study by sectioning, but the procedure remains too time-consuming to happen intraoperatively. The greatest competition comes from Dune Medical's margin probe, which senses the bioelectrical differences in cancer cells, which have a signature response to an applied EM field caused by membrane depolarization, changes in nuclear morphology, increased vascularization, and poor cell-to-cell connectivity. While at 20 to 30 minutes, this is quick enough to be intraoperative, it is affected by the presence of a guide wire or any electrolyte such as saline solution or electrode gel. Their main advantage comes in the fact that they are very close to coming to market, having received their FDA PMA on December 27, 2012. This could allow them to become established before the quantum dot solution can be brought to bear on the market. However, tests suggest that they have only 80% specificity. We therefore believe that the proposed product's 95% specificity, inexpensive manufacture, and ability to preserve tissue for follow-up study lifts it above the competition. However, there are still risks, specifically the limited shelf life of bioconjugated quantum dots and the possibility of human error during the labeling procedure. An overview of the intellectual property protection for the product shows that while an international patent for the process in question has been applied for, it has yet to be granted. However, a number of patent protections exist for the aqueous quantum dots and their manufacture. As far as conflicts are concerned, no patents exist that are in direct opposition to the product. However, Lumicell Diagnostics applied for a patent in January of 2011, which amongst its claims covers margin determination by spraying or painting with a molecular imaging probe. Another possibility exists through this application by the Institut Curie for a proprietary TN antigen antibody. While not in direct conflict to our product, it opens the door for circumventing the proposed solution by coupling the proprietary antibody with a different signaling molecule such as GFP or another nanoparticle. A look at reimbursement shows a very positive landscape for the product. This technology can bring many benefits to patients, hospitals, and insurance companies. By giving quick and effective results, it can reduce procedure times, lowering costs for hospitals and sedation time for patients. Currently, pathology reports can take a week or more to determine a failed margin, at which time re-excision must take place. This added trauma is hard on patients and leads to poor patient outcomes. Furthermore, Medicare and other insuring bodies are moving to not pay hospitals for readmission cases, so reducing these incidents will benefit both parties. In order to receive reimbursement, two strategies are possible. The first is a new code, which while desirable is very difficult to achieve, particularly for a startup venture. The second is bundling with an existing code. Because this test can be considered to occur within the context of a lumpectomy, we think it is very likely it can be bundled with that existing code. A quick look at the published Medicare rates show that for outpatient lumpectomies, hospitals are reimbursed $1,784, or as much as $3,141 if lymph node removal is also necessary. For inpatient procedures, the payouts reduced to $1,029 and $1,812, respectively. However, we believe that when factoring in the value of the product, consumers will be willing to consider this bundling strategy. In conclusion, there is a clear and definite medical need for an effective and highly accurate intraoperative margin detection test. The proprietary Xi aqueous quantum dot conjugated to TN antigen antibodies offers a very promising solution to the problem. Competition for the product is limited, with Dune Medical's margin probe being the most likely competitor. Furthermore, IP protection seems very plausible. Reimbursement seems promising by adopting a bundling strategy under the current lumpectomy procedure codes. Thank you.